What if the future of medicine was not decades away, but already here? Today, Dr. Marschall Runge returns to WellWaveNOW to reveal how big tech, bold policy, and radical innovation are transforming healthcare and what it means for all of us. Welcome to WellWaveNOW, your portal for actionable wellness insights. We, Brett Rice, Dr. Bob Levine, and myself, Tim Daniels, are your wellness catalysts committed to elevating your health, enhancing your functionality, and optimizing your performance at every life stage. WellWaveNOW, where timeless wisdom lights your wellness path. It's a privilege to welcome back to the show Dr. Marschall Runge, an esteemed leader whose decades of work as a physician, researcher, and executive at Michigan Medical have placed him at the very center of American medicine's evolution. His new book, The Great Healthcare Disruption, Big Tech, Old Policy, and the Future of American Medicine, offers not only a compelling vision for the future of healthcare in the U.S., but a candid guide for how to get there, rooted in experience, innovation, and practical reform. Dr. Marschall, welcome you back to WellWaveNOW.
Great to be back, Tim, Brett, Dr. Bob. Great to see you all.
Yeah. So, Dr. Marschall, thank you so much for being our guest again today, our expert guest. And how have you been since our last show?
Been good, been busy, lots going on. But as you know, lots going on in health across the United States, and same in Michigan.
Yep. Yeah. And you, I love that you used the terminology disruption in this new book of yours. And anyone that knows me, follows any of my social media, you'll see that I use healthcare disruptor quite a bit in there too. And so I love that terminology. I love what it means, and that you've put that in the title of your new book, The Great Healthcare Disruption. So let's jump into that. Why now, and what inspired you to do this book at this time right now?
Well, Forbes, it's a book that's a Forbes book, called me up about a little over a year ago and said, "You want to do a book on health?" And I said, "Sure, I'd love to." I said, "What about health?" They said, "Whatever you want to write about." And I said, "Well," and then we had several conversations, but ultimately at the time, I said, "There's a lot of change going on in healthcare, a lot of new entrants into healthcare. We have problems. We don't have enough primary care. We don't have enough preventive care on the one hand. On the other hand, we have all these new technologies." And they said, "Write about all of that." And so I did, got a lot of input, learned a lot. But at the end of the day, I wouldn't have ever thought that healthcare would be changing so dramatically as it is today, due to all kinds of forces. But fortunately, almost all these topics that are germane today are part of the book. And it's, as you may or may not know, it comes out next week, May 6th. It's already available for pre-order on Amazon, but it'll be in bookstores everywhere. And I hope that people will take a chance to read it, because it's a nonpartisan, totally unpolitical view from somebody who, as Tim said, has been in healthcare basically my whole life. And I want people to think about it, ask questions. And again, privileged to be here to talk to you about it today.
Thank you. And so along those lines, when you say people, who are you referring to? Who's this meant for? Is it meant for policymakers? Is it meant for the consumers? Is it meant for practitioners? What was your scope? Who were you trying to address in this book, Dr. Marschall?
Well, I wanted to reach out to a broad group. So all of those people who are interested in healthcare for their own health reasons, or for those of a friend or relative, policymakers, healthcare providers, because it's quite a broad book, and I think there are topics in there that are of use to everyone, and also people in roles like mine who are thinking about what will the next 5 years bring, and how can we focus our efforts on trying to improve health, as well as people like all of you who are thinking, how are we going to have a healthier country, and what can we most do to have impact? And I know you are already.
Yeah, you've seen healthcare from multiple vantage points, right? Hands-on in your practice, academic, administrative. What really is the inspiration that you draw on most in this book?
Well, it is, I'd say, two big areas. One is the practice of medicine. I'm a cardiologist, as you know. The other is education in medicine, medical students, residents, specialty trainees, and then how those come together in health systems, whether it's an academic medical center like Michigan Medicine is, or whether it's a small rural hospital or a group of small rural hospitals, or everything in between. So I just left a meeting that's a annual meeting held in Chicago by Becker's Healthcare. And it was interesting. I spent a couple of days there, gave a couple of talks and panel discussions. But what was really interesting was to hear, it's almost like the people who are touching different parts of the elephant and don't really know what it looks like. They're thinking about different parts of healthcare. And really fascinating hearing them talk to each other about these topics.
Okay, so we start out, we referred to the various stakeholders you wanted to pick up this book and do something with. And we've talked in the book about the various influences that are shaping healthcare as it changes. So let's look at one component of those, the technology and big tech, show up throughout your book on there. So what's their role and how are they reshaping today's care and tomorrow's care?
I think technology is going to have a huge impact in a couple of different areas. I'll start with one that's actually easier to describe, although it's not simple, and that is the development of new types of therapies, either preventive or for treatment of all kinds of diseases. I'll give you two examples. One is the so-called weight loss drugs, the drugs that stimulate this pathway that's defined by GLP-1. And those drugs are definitely the result of high-tech investigations. Not everybody needs to take them, but it turns out that they not only are highly effective, they started out as diabetes drugs. They're great in diabetes. And so people who have type 2 diabetes, and they're now being studied for type 1 diabetes, their hemoglobin A1C comes down dramatically. Their complications from diabetes come down, from stroke, heart disease, you name it. But they're also turned out to be very effective with weight loss. And finally, they're incredibly effective in terms of other, what I'll call addictive behaviors. That these involve an area of the brain that, when stimulated, secretes dopamine and gives you that brief burst. So it's the same area if you eat some sugary food, which I fall into that trap too often, gives you a buzz, or caffeine, but also alcohol or opiates, or many other things stimulate that pathway. And these drugs have been studied in those areas and seem to be effective. They're not approved in all those areas yet, but they are being studied. And then to go all the way to very high-tech drugs, there are new RNA therapies that are targeted for a very small group of people, almost called these orphan diseases or rare diseases. One treatment in a child with one of these drugs that prevents a deadly disease prevents it forever. But those therapies can cost $1 million for that one treatment, or $2 million even. So that's one high-tech part, which we'll have to figure out, how do we pay for all that and how do we use it properly? But on the other hand, there's tech that is doing all kinds of things that I think are good for health. And I'm going to put it in the big category of AI. And my view on AI is that can be such a help to both people, patients, to healthcare providers in many different ways. I don't want to be talking a monologue here, but I'll be happy to give you a couple of good examples of that if you'd like.
Yes, please.
Well, one is it's going to start out sounding a little odd, but it's the idea of AI assistance. So an assistant, if you have an assistant, it's somebody who helps to get things done. The concept that I'm most familiar with started at the University of Michigan, where the IT group for the University of Michigan developed AI assistants, which were available to every undergraduate who started in last September. And initially, these assistants, the idea was, well, if I missed a lecture, or I didn't get the notes, or I didn't get the slides, it could find those and bring them to you. But another role of it, which has turned out to be really cool, is to help students learn. So I don't know about any of you. I do my best learning. If I'm reading about it, I'm sleeping about it. If I'm listening to a lecture, I'm pretty close. Where I really get engaged is answering test questions. And I have to recertify, and I'm recertifying in my ACLS training right now. So that's what really works for me. But different people are different. And an AI tutor can figure out what works best for you with your learning, and then help provide information that will help you with your learning. So it's really helping with learning. It's not replacing, it's not cheating, it's helping people learn faster. So that's one example.
And so do you see that? So when it's help in your scenario there, where's the impact on who it's helping learn faster? Is it with the practitioner? Is it with the patient, or where's that?
Well, thank you, Tim, for clarifying that. I didn't never got back to health. So it's for it could be for patients. And there at this meeting I was just at, there were several AI startups that were looking either at patients or at providers. And if you're a patient, I know this would never happen to any of you. Saying this tongue in cheek, having trouble getting an appointment, but doctors are so busy these days. It's so difficult.
Mhm.
But if you had an AI assistant who could help you get an appointment with the right doctor at a time that worked, rather than you having to make 10 phone calls or wait online with a call center for 10 or 15 minutes, that's a simple example.
Right.
Another example might be just to help you understand if you're having trouble with a therapy that's been prescribed, what's the next step? Should the next step be calling your doctor's office? Should the next step be stopping the medication or the treatment right then, and sort of everything in between? So it could be that. It can also be for healthcare providers, and it can work in lots of different ways. The one that I like that's currently out there has to do with what's called ambient AI. So AI listens to a conversation, and it's not just transcribing it. What it's doing is taking that information and putting it in a format that looks just like a very, very good medical record note. And so a physician or non-physician healthcare provider gets a note at the end of their encounter. So rather than me sitting here, I don't know if we're televised or not, but typing on my computer while we're talking, which many doctors have to do to keep up, you have a conversation and then it's captured. And to give you one thing to really make it make sense to you, I don't know if any of you have looked at your medical records, but if you look at your medical records, they are page after page after page after page.
Right.
And I did this experiment because somebody said, try this. And I took a thick medical record and I made a PDF of it. That's right, Dr. Bob. I fed it in what was kind of 60 pages of jargon and mumbo jumbo, it gave me 2 pages that gave me everything I needed to know.
Yeah, that's
Wow.
great. Yeah.
So these technologies are going to be great.
Yeah, AI is pretty, I think for me, it's accessing information fast is the best. And I think patients need to learn how to use it. So because sometimes they hear words from the doctors or the nurses or the other healthcare providers that they don't understand, and they can look it up really fast, and they can ask a patient could say, I have these symptoms. What questions should I be asking my doctor? And then are my doctors proposing that I should do this, this, and this? What are the pros and cons of that? I mean, AI will spit it out in, literally seconds.
Yeah, I love how Dr. Marshall puts in his book that AI is as impactful today as the discovery of fire. That's a pretty impactful statement right there. So, with AI though, there's a lot of excitement behind it, but there's also a lot of concern too. Yeah. So, in healthcare, how do we make sure that we're not losing that human element?
Breck, that's a really important point, and part of why I think it's so impactful. And there's a chapter there about technology and AI and great healthcare disruption. The part of that is the pace of it. So if you think back to when the internet became available, I mean, it was a decade before it was really
everywhere
where it is today.
Yeah.
AI was there in 6 months. And what you say is so true. We have to, and I think healthcare providers and WellWaveNOW and others need to emphasize to people, you're not talking to a person, and it is a great source of information that you probably should run by, or in anything really important, you ought to run by an expert. In this case, it's a healthcare provider. Could be a pharmacist, could be a advanced nurse practitioner, it could be a doctor, but because what AI knows is what you put into AI. So AI doesn't know that maybe you've got something else going on in your health or in your life that you didn't mention that could be really impactful. So that's I think your point, Breck, is just right on target.
Yeah. One more thing in that line of thinking is that there's so many different AIs around. There's so many dozens of them, and people are creating them as they need it. So I think the one message that I always tell people is, don't rely on one AI tool. query several AI tools and see what comes up, because I've gotten wrong information from certain ones that are otherwise highly reliable. And so the last thing you need is to get the wrong information that 1 out of 20 or 30 times that messes with your life or messes with something else, So
Yeah, a great point. And AI, it depends, but it often has access to other more conventional medical information databases like Medscape or UpToDate. I don't know if it has UpToDate or not, but you can feed it information and ask it, is that what Medscape says? Just as you're suggesting, Dr. Bob. So, and I've done this sometimes. I've taken, I took The Great Healthcare Disruption, had a PDF. I fed it into AI, said, have you read this? And 30 seconds later, it had read it. And so I asked it some questions that I was wondering about it. And it had read it, it understood it, and it was right on target.
Beautiful.
it's incredible.
Yeah. So I think that's a good use of the AI. You talk about how it can benefit the patient and the practitioner with the notes. One thing on that, I'll make one comment on that, is I think it also has, in listening, has the potential to make the action even more human. Why do I say that? As I fed into AI one time this note I had gotten back from someone, say help me for my response, and it came back and it said, Dr. Bob's getting pretty defensive in this note.
It really said that about me. I can't believe it.
So and it said maybe you want to respond this way. So it picked up, and it wasn't Dr.
It picked up the nuance. It can pick up the nuance, though, is what
Yes.
you're saying.
That's right. It picked up the nuance.
That's
and
wild.
so it could have, I could see in these conversations, it could pick up, well, it sounds like if we're watching, you sound like your patient's confused. They don't really understand.
Ah.
It sounds like they're a little fearful here, because it does have that ability to sense those things.
I just got a great idea, Tim. Thank you. I'm not
right.
going to talk about it because it's off target, but
All
thank
right.
you.
So with that though, and I love how we went down this part of your work in the book and what you talk about. But there was a thing earlier that caught me as well, where you talked about the development of preventative therapies. So if I take a look at it, I think of we've talked about lifestyle things as preventative these days, but aside from that, vaccines as being preventative. But what do you think is driving? Is it technology? Is it focus? Is it request? What's really driving now these the drive towards more preventative versus treat? What do you think, Marshall?
I think there are many different forces that are leading people to think about prevention. I think today people in general think more about prevention than they did 20 years ago, where they thought, well, I'll just go to the emergency room or I'll go to the doctor. I'll make a couple of comments. I'd love to hear what you all think, because I'm not sure what the major drivers are. It doesn't hurt, though, a bit that this has been a focus of the administration, prevention. And I think there's so much we can do with prevention. One way to look at it, and I don't use exactly these words in the book, but I think prevention and health promotion, that's the salvation of American medicine.
Yes.
Truly, I believe that. So in the book, I talk about the cost of healthcare in the United States compared with other peer countries. It's way higher. But for example, if you look at the number of primary care providers, it's just flipped. The United States has far fewer primary care providers. And I'm using the broadest term for primary care providers.
And then more specialists, you're saying.
And many more specialists.
That's interesting. That's really interesting.
Yeah.
And so I think that sources like you and others can really speak to how you can make yourself not just healthier, feel better. I'll give you a stupid example. So I've been working a lot of hours lately, and it just seemed like, man, my legs are getting tired, and maybe, as a doctor, I can imagine all kinds of things. But then my wife said to me, you're not exercising very much, and you never stretch anymore. And so just in the last 4 days, I've been doing not incredible exercise. I've gotten on the treadmill or gotten on the stationary bike, but I'm like stretching every day, twice a day. Man, I feel so much better. I mean, that's a dumb little example, but
And that's not dumb. It's actually perfect. I mean, that's what people need to hear. People need to hear they need to do things. So
I want to ask, before I get back to ask you about what do you think the most important sources are. I want to ask if you, as a group, would think about something that has just kind of come to mind to me lately, and it does have to do with people's concern about vaccines and obesity.
Mhm.
Used to be there were health programs in schools, and so there was even a health class, and I'm talking about in primary schools, elementary school,
Mhm.
and I think that's all gone away. And I wonder if, with enough enthusiasm for that, that you might be able to bring forward, if we could get some of that back into the schools, because at those ages, man, they're a sink for knowledge.
Right.
And if we can provide that to them, I think, man, could that really have an impact on health in the United States? It won't be tomorrow, it won't be next year, but over the next decade.
I agree with you 100%. That's a
Well,
beautiful thought and vision for the future. I mean,
absolutely. I think there's a person who we've associated with, Bernard Robinson, who's a former retired, well, he was former NBA player, and he was always very focused on just what you're talking about, saying, the information here and how we approach this, it ought to be brought out and taught to kids as they're growing up. So if you really, so that it's just, we talk about, it's not just biology at some point or this, it's really, here's your body. How do you manage it? How do you get the most potential out of it? And how do you look across and maintain your health, across the spectrum of your life? And how to be started at very, 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 very early and taught, started part of school. So absolutely.
Yeah, coming full circle, obviously we want to get to the youth, right, and start educating them. But CMS for Medicare and Medicaid, they understand the costs of preventative versus, reactive medicine. And I get the pleasure of working with a gentleman who helped CMS create the quality measurement scores for providers. And there are some clear care gaps that are there. And you mentioned to it, referenced it earlier, Marshall, that it takes a while to get in to see your primary care provider. You may be 2 or 3 months before you can get in for a well care visit. Well, there are 16 preventative health screenings that can be done if there were enough primary care providers. So filling that gap is such an important, that's part of my mission right now, and working with doctors and our community pharmacies to be that community care gap filler. And there's so many opportunities on both ends of the spectrum, education and then also doing those preventative screenings for sure.
Right. And now we're going to get back to you soon, Dr. Marshall. We're going to stop you from engaging us. This isn't you engaging us. This is us engaging you and featuring the book. But as part of that, before I do so, I would remind our listeners and our audience and people who then pick this up, that I think we've spent a good amount of time on prevention and optimum performance, because Dr. Marshall said it goes just beyond just being healthy. It gets through my term now, being wellness and thrive. But we've got a whole series on exercise as medicine, Dr. Marshall, up there. It talks about stretching. It talks about what does resistance training do for you? What would Tai Chi and Qigong do for you? And it's not about aesthetics. It's not about even fitness. It's really what are the physiological changes that come about through these things. And even a part that Dr. Bob and my wife have come to love is called movement snacking. How do you do movement snacking? And that's what are the central movements doing. So that's up there. But we've even got things on there on supplementation. What's the right supplementation? And supplementation for longevity, supplementation for performance, on stress relief. So we've got a whole thing up there, a whole part of our being is to have those things up there to stay focused on those things.
You know what the problem is though, Tim? That's the information is missing. Like Dr. Marshall said, that information is what's missing in the youth.
Right.
I remember when I was a youth, we got a lot of exercise because we were out there. There wasn't as much electronic stuff going on, but nobody told me how to care for my body as I was heavily into sports. Now I have, 3 ACL reconstructions, 2 hip replacements. I'm turning into a bionic as I limp around a little bit. But the thing is, if I knew a lot of the things that I know now, and also the diet, even though I think we were eating better food back then because it just wasn't as kind of contaminated. Nobody told us about sugar and the effect of high sugar in the bloodstream and what the deleterious effects of that. So the information that Tim was just talking about, that's the kind of stuff that's really missing. And I'm wondering how we get it there.
Hey, we've just what Dr. Marshall's been plugging us. We get out there one way that's part of our impact is get it out there, and the more our content is not restricted by age, and so hopefully they'll find us on their own on YouTube as well. But also, the more parents, the more young adults we get out there, the more they can put it through and advocate it. So that's part of that's our approach to it. But I think there is, as Dr. Marshall mentioned, there's a overall advocacy that could be done out there amongst the general population to bring it back and put it in the schools as well.
That would be great.
I was alluding to, new places of where care could take place, like screenings, for instance, and we've kind of already adopted that with our vaccinations, right? You don't have to wait for an appointment, 6 months down the road to go get a flu shot. You can just walk into a community pharmacy and get that now. So there has been some shift in trying to fill these gaps of care. You talk about new places for for hospitalization or the recovery for hospitalization. Let's get into that. Where do you see the future of recovery happening, not inside of a hospital?
All right, right before you do though, I just gotta say I did love this other little quote you had in there that fits that. It was the right care at the right time at the right place. So that's what I would kind of summarize this section we're diving into here with you.
Yeah.
Yeah. It's a great topic. And I think that we can do so much that doesn't have to be done in the hospital, which is really expensive, but also is better done outside the hospital. And so this is a whole range of healthcare that doesn't have to be in the hospital. And I'll give you one example that I have personal experience with, and that's falls under the genre of care at home or home health care. Not the kind of home health care that we're all used to where your great Aunt Bessie can't get around and somebody comes over and gives her a bath every day. Not that there's anything wrong with that.
Oh, I did that I had a company that did that for 8 years, like Marshall, in 3 states.
Well, Tim, this might just be a small pivot for you. So, no, I'm serious. So we can do a lot, and some of that is the availability of technology, both generally and with wearables. So the example I'll give you is I had a hip replacement, and I had a rare complication of a hip replacement, very rare complication, that kind of put me in a place in the hospital I didn't want to be. So usually get a hip replacement, you go home the next day or the same day. Mm-hmm. And I did actually go home the same day. And then I came back and I was short of breath and doing terrible. And they thought, well, maybe I had a clot go to my lungs, but it wasn't that. It was tiny little microemboli that came from having the surgery. So little tiny fragments of fat had gone to my lungs. So I was after the first 6 hours, they put me in the ICU. Mm-hmm. And then it started getting better quickly. And so after one day in the ICU, I felt pretty good. And I talked to my doctors and the staff there, and I said, how about if I go home and get care at home? They're like, whoa, wait, we don't do that. And I said, I promise, I swear, my wife will keep a close eye on me. And if I'm having any problems, I'll just come back. And so after, watching me for another 6 hours, I said, okay. So I went home. I had everything I needed was there at home when I got there. I had instant access to a nurse. I had access to a doctor if I needed it. I had daily call-ins with what was going on at a blood oximeter, and I had, blood pressure cuff and things like that. And I had a wearable. And it took me, for, I don't know, maybe 3 or 4 days before I really felt back on my feet again. I'll tell you, if I'd been in that hospital, I not only would have been put in an asylum because it was just driving me crazy, but I'm convinced that I got better much more quickly having gone home. And the first day they sent out a physical therapist mm-hmm. who was, had me back on my feet and had me doing exercises that I needed to do from that standpoint. So take that a different way. We see a lot of people in an ambulatory setting, in a clinic, who they're not right. I mean, they've got something going on. And the default is to send them to the emergency room, and where they often wait hours and hours. And the default in the emergency room is, if you're not quite sure what's going on, to admit them to the hospital. And there's a large group of those folks who also could get this kind of care at home. So we're not very slick at it yet. We're working on it here at Michigan Medicine. But I think it's that kind of care that we could do that actually is better for people. Right. And during that time, I had, the therapist would talk to me about my diet. If you're not seeing video, I'm covering my eyes and my ears. But talk to me about my diet and how my diet might have impacted my needing to get a hip replacement and carrying around too much weight. And it was good. It was great.
Yeah, I think you're right on. I mean, I think everybody, you ask any physician, they'll tell you spend as few days in the hospital as you can because
Yeah.
it's just more dangerous there.
Yeah.
And like you say, a lot of it can be done at home, and I think it's beautiful.
Well, I have a very important question about that right after the break because I want to understand where you think we're headed, what the future is. But this episode is brought to you by Better Alt, committed to supporting and enhancing your well-being, according to independent studies and also PubMed.gov, which is one of my resources I go to quite often. But I want to incorporate some of your resources too that you rattled off, Dr. Runge, as well. But according to these studies and PubMed.gov, this supplement it has 87 of the 102 trace minerals. Oops, got to get that so you can see it. There you
go. Yep.
87 of the 102 trace minerals that your body needs to live, and it improves your energy, enhances cognitive function, supports healthy aging while boosting your immune system. It's the USA's #1 brand of pure Himalayan Heligy. I've got the honey sticks here that I enjoy, all by Better Alt, available at thebetteralt.com. GNC and other fine retailers, also on sale in the TikTok shop. We'll leave a link in the show notes for you. So my question.
Okay, wait a minute. I just want to piggyback on that. I just want to, this morning I mineralized with exactly what you're talking about, and I've been doing it like for a long time. It's really great, really important too. Anyway, go ahead.
Really important. Yeah. So, Dr. Runge, what is the future of the brick and mortar hospital? If we go this route where we can do more of the recovery at home, will it be more surgical suites and home recovery? What is the future?
I think that the future is going to be that what it should be, and that is the most acute care, which is many of us need from time to time with life-threatening diseases or major surgery. That, of course, should be done in hospitals. And I think hospitals will become more and more acute care facilities where a lot of what we do in hospitals now does not need to be done in hospitals. For example, a simple example, somebody's blood pressure is too high and it's not coming down on the first drug we try. We might keep them an extra day or two to try medication. That can be done at home very safely. So we're just getting ready this fall to open a new facility at Michigan Medicine. We've been working on it for 5 years. It's our publicist, I love this term, I didn't come up with it, called it the Hospital of the Future. So it's got 24 advanced operating rooms and procedure rooms that have every bit of technology you can imagine, including robotic surgery, the whole spectrum. And it's got 264 beds, and those beds are what are called universal beds. And what that means is every one of those 264 rooms is equipped so it can either be a regular floor bed, or it can go all the way to an ICU bed. And the only difference is the staffing. So in an ICU, you have one nurse for 2 patients, or sometimes one nurse for 1 patient, or in the sickest situations, 2 nurses for 1 patient. But it has everything that's needed to take care of the sickest patients in the world. But also, it can just be a regular hospital bed. And the reason I think that makes so much sense is because if you go to the hospital and you're admitted to a bed and then you start doing worse, we have to find an ICU bed and then move you. Or if you're in the ICU and you're ready to go to a standard floor bed, we have to find a floor bed and move you. In this case, all we have to do is adjust staffing appropriately. So I kind of think this kind of model is going to will gradually take over how we do acute care, and it's acute care that's so expensive because, as I just said, if you need a nurse and a therapist for a patient plus all the ICU equipment, that's a very expensive day in the hospital. Whereas if you don't need it, you don't need it.
Well, we have a lot of hospitals all over the country that were built, anywhere from 5 years ago to 50 years ago.
Right.
My question to you is, and I'm not sure if you can even address this, but how do you think some of the older hospitals need to be reconstructed to accommodate the new way of doing healthcare, which is on the way coming?
Yeah, I think they need to be repurposed. So our main hospital, it was built 50 years ago. and it's been maintained, but it's nothing like this new facility I just told you. So once we get our new facility up and going and we're more effective in keeping people out of the hospital, we'll go back and try to repurpose our main hospital. And I think that's, and the structure of the hospital is fine, the infrastructure is fine, but it needs to be repurposed in terms of what care it's capable of providing.
Okay. So you've got that from the sort of brick and mortar portion. And then as the other parts of this right care at the right place at the right time, what are the constraints on that now? What do you think needs to be addressed to be able to scale that?
I think that we need, and I'm not saying it's all wearables, but I think wearables are an important component of it.
Mm-hmm.
I think prompt.
When you say wearables, could you just expand on that briefly?
Yes. So it might be watches that are smart watches that can get heart rate, blood pressure, etc. It may be other types of wearables that gather more other information. For example, there are wearables that can determine whether you're getting enough, what your oxygen saturation is, what the blood in your oxygen is, what the oxygen in your blood is. And these are being used in some cases for sleep apnea. You can now do a home sleep apnea test. I don't know if you've ever had to go have a sleep study, but that's no easy thing to do.
Yeah, I got the sleep apnea test done at home. It was interesting. It was easy. It was simple.
Yeah. So it's easy to do at home, much less expensive. So I think a combination of technology and smart use of it. What I think we have to be a little careful of is there are so many, and I do talk about this in the book, so many very cool sounding entrepreneurial companies that are being formed that we'll have to think about each topic of those. And unfortunately, like most business startups, many of them won't survive. But I think we have to pick the best of the class and then figure out how we optimally use those.
Yeah. I just checked my heart rate, 79. Is that okay, Dr. Marschall?
Kind of high.
Well, you probably would be much lower, except it's so exciting.
It is so exciting to talk to you, Dr.
That's what I was about to say. Normally, Breck, you have a resting heart rate of
like a 60 or
of
something.
that marathoner that you've been, like at 38 to 42, but Dr. Marshall's really got you revved up here.
Wow, man. I'm so revved up, I'm not even going to check mine.
But career one, I was a technologist. We talked about career two, right? I had a home care agency for the elderly, operated in New York, Connecticut, and New Jersey, and we were doing we were doing range of motion assisting and some rehab, and so you got some of the stuff you're talking about there. But career one, I was a technologist, and so I've kind of stayed abreast of that a little bit. And I just saying there's a lot of technology coming to that home care world that you talk about in general, and that's in the book and elsewhere. I came across one just the other day that's actually a mat that can be placed underneath the coverings on the bed, and it will take the vitals of a bed palpation and report it back. There are things out, and so you've got the core, like you alluded to, you've got the core ring and other things that will monitor how one's sleeping, feed that in there, the Apple Watches. But you've got all those things out, and things being tied in. The other thing that I think, for might also apply, that does apply, it came out for the elderly, but could apply to your subacute and keep them safe. There are things that will monitor in someone's home, or are they taking their medication and provide medication reminders.
Oh, you got the ring.
Right.
I was saying we're playing around.
Hold on there. And then there are things that will say, have they gone to the bathroom at the right time? Are they falling down? So I think all those home monitoring technologies are there. It can be easily adapted from the elderly market to how do you provide additional level of patient care to it.
That's exactly where I was going. We're actually playing around with a technology right now that takes 30 seconds to do a facial scan, and you're getting biometrics from that. You back up, you can look at the gait of the patient and see how stable they are just by walking. There's so many incredible technologies right now.
Right, and you had done some playing around early on. Would you take the technology break that actually would to the part about the physical therapy? Marshall, you mentioned you had and I've got to remind the audience. So Marshall keeps telling us to call him Dr. Marshall, call him Marshall. I'd rather call him Dr. Marshall. So I slip up sometime and call him Marshall because that's what he told us. But Dr. Marshall talked about his rehab at home. Breck, you for a while you had played around with some technology that could actually say, was the physical therapy being done correctly by someone?
Yeah, it was virtual physical therapy, right? Because of COVID. And so you could still, monitor, put a wireframe on the patient, make sure they were actually doing the proper exercises. And, if it's something as simple as a squat, did they actually go down far enough? Oh, no, you're only at 60%. Okay, now 70. Okay, now you're 100%, come back up. Yeah, some really great technology out there.
Right. But I think what you talk about that right care, right place is, I think technology, and you talk about the AI and other technology, I think that is enabling that to be, and very, very soon to be able to scale.
One thing I want to mention that I think is also so important, and that is we have to try to figure out how we avoid having our care fragmented. So what I mean by that is, let's say I've got a cold or some problem, I want to call the Amazon clinic or call another 24/7 telehealth clinic. We don't have a means to that person who I see has ready access to my medical record. My wife told me that she'd seen an advertisement for Amazon that if you think you have a urinary tract infection on your flight, you can contact Amazon. Your antibiotic will be there for you when you get home. I mean, that does sound great. But we've got to be sure that all of our records are talking to each other. And even though we have some very good electronic health records, the interconnection of those and what's called interoperability is poor. And that was part of something that was proposed more than a decade ago. And so I think we need to have that so that we're can be sure that our what's going on with our healthcare is well known to everyone, and that we see in terms of healthcare. And it's not sexy and it's not cool, but it's so important. And I hope that can be part of what people are thinking about, and from a technology standpoint.
Okay. So along those, well, maybe along those lines, but yeah, I don't know if other countries are doing that better, but you talk a lot about other systems around the world, the U.S. system. And as you talked about earlier, we spend a lot on some of what we do here in the U.S. is very costly. And you talked about the difference between how many primary care physicians we have versus others. So when you compare and look across the globe, what are some best practices? What should we look to adopt from elsewhere? What should we leave behind? What should they look to adopt from us as we move towards your vision for the future, Dr. Marshall?
I make a case that will be controversial to some in the book, and that is, I think we need to have a base level of healthcare that everyone has, and it doesn't have to have bells and whistles, but it can be something that also aggregates health records. And I think there are good examples of that around. Many of the countries that I talked about that have, you might call a Medicare for all or something like that.
Mm-hmm.
In some cases, they're better than others, but it's very common that people have supplemental insurance on top of that. But the difference between commercial insurance and a long-term single provider of again, a base level of healthcare is that insurance companies, they have to file their profits and losses every quarter or every short period of time. And so decisions are made based on that sometimes rather than what's going on in the big picture. And so I think we, whatever it is, and I'm not proposing anything specific, I think we have to have longitudinal healthcare. And that has to incorporate also preventive healthcare and the concept of living more healthy. When you're showing the supplements there, Breck, I was thinking about, there's a chapter in the book about longevity, and people are going to great extents to try to figure out what are the necessary components of living a long time.
That's hard. That's really hard to know because you can't do studies like that. They're so expensive.
Right.
It's it's a lot of guesswork for sure. But what you're saying is really important about how do you live the longest, healthiest life, right?
Yeah.
It's just not easy.
Well, in your book, Dr. Marshall, you seem to be transitioning a little bit, supporting more of the federal role in basic care. What was that shift in thinking? What made you decide that, hey, maybe the feds need to be more involved?
Yeah. Well, what took you from a conservative Texan to an enlightened Michigander?
It's nothing like that. But if you'd asked me about this, certainly 10 years ago, maybe 5 or 6 years ago, well, more like 10 years ago, I would have said that's nuts. And but in the last 10 years, I've had different kinds of experiences that I want to tell you about. So one is there are a group of clinics that are called federally qualified health centers, and they are present in urban, rural areas. They take anyone who comes in, and they do get supplemented from the federal government. But I started working one of those, now it's been 20 years ago, and I would go half a day every other week, and I'd see cardiology patients. And what I learned is healthcare is practiced in an entirely different way in those clinics. It truly is a medical home, and patients there have access to anything you might need in terms of your health. They have pharmacies, they have dentists usually, they have therapists, they have social workers, and they work together as a team. And that's what I call a medical home, which I haven't seen done that well in any other setting. I've spent a little bit of time in VAs, not very much, but I think I admire them for their mission. But the last example was last summer, I had always thought about the public health service. I never went into the public health service, but I had an opportunity to spend time in northern New Mexico on the Navajo Nation in a Indian Health Service hospital, small community hospital, about 60 beds. And they care, the population is sparse there, so they care for a huge area. They go out to clinics, and it almost brings tears to my eyes. The providers there, the family medicine providers, the general internists, the obstetricians, that's what they have. They don't have specialty care. And the nurses and the therapists, I mean, they are really dedicated to the mission.
Yeah.
Now, that's not everybody, but the care that is provided to those who come to those hospitals is just exceptional.
I do see that in the rural areas, right? But I think I'm still 10 years behind then in my thinking in more of the metropolitan areas because, do you really want your health system run like the DMV? I mean, when's the last time that you ran and, wanted to run in and just get something taken care of at the DMV? It's an all day experience.
Right. So the question is, can that be done? And I don't know the answer to that. And so that's why I think I wrote the book, it was finished 6 months ago. If I had to redo that last part, I would talk about the importance of longitudinal care. Does that have to be government longitudinal care? I don't think so. But we do need longitudinal care. And part of the reason I wrote that section of the book in the way I did is because I think government health programs they have a bad name. I mean, it's like the DMV. It's like, and so if it can't be better than that, it's not going to help anybody. The question is, can it be better? And so I mentioned a couple of instances that I personally have experienced that it was done very well.
One of the big problems that I see in this as we discuss this, in the future of healthcare, is that the human condition, the human being, can withstand so much in terms of insults, health insults. I would say cigarettes, drugs, bad food, bad diet, stress, all these things. And people live a long, long time with all that stuff before they start breaking down. And then, we have to take care of them as they're breaking down. So the issue is going to be, how do we get everybody early in life to understand how to be more healthy?
Yeah. We've talked about a lot of it, early education. We've talked about the importance of health promotion, the right care at the right time. I think that, and technology. I think technology can really help us. So I'm tacitly enthusiastic about the future. I think we can make a little bit. We're not like turning the Titanic, or that's a bad analogy, turning a ship. But I think that we can make pivots that will make us a healthier country.
And so to help with that pivot, you talked about this longitudinal care, about the healthcare record, and you mentioned some of the policy thing. And I've got to say one thing before all the Texans come after me before that. Although I'm probably less conservative than I was years ago, I was a very conservative Nebraskan. I've been worked on by others, so my Nebraska friends saying you're changing on me, but they still they still say you're still a good conservative Nebraskan too. But with that, policy, and you alluded to the government policy a little bit earlier, maybe that's a help. What is, from your book, what one policy change do you think you would really like to see happen that would make a big difference at this point in time?
Whew. So many things. So what would the one be? It would be to incentivize and reward health promotion and access to primary care. So, right, one of the reasons that we have some of our students going to primary care, they come in so passionate, and then actually we're part of the problem. They see everything cool that's going on in terms of advanced procedures and surgery and technology, and they think, well, I'll do that. But I think if we could find ways, and I'll tell you one way that has been effective in some states, I think that the government and people getting behind the support of that is really important. And that's where I'd if I had one wish, it would be for that.
Right.
I was going to, I forgot what I was going to say. Anyway, go ahead.
Go ahead, Don, with your example where you said you could give us one example of where that's taking place.
Oh, yes. So part of this is public health service. So as you may or may not know, doctors can still do this, but during my era, many doctors joined the public health service and they got their tuition paid for, but that included a requirement that they spend 4 years in the public health service in areas which need healthcare. There are states now that are doing that to a modest degree, where it's a loan repayment model. So it's not, you have to take out a loan for your medical education, but everyone knows what a burden that is on people. And that's part of the reason people don't go in primary care. They're worried they won't be able to pay back those loans. But if you then spend, and I don't know, the requirements vary, but complete primary care training and spend 2 to 4 years in a primary care practice in any setting, then you get your loans repaid. And something like that, if you tell people you get a free ride and go into primary care, a lot of people are going to take you up on the free ride, and maybe some of them will go into primary care. But if you make it a requirement, or I'm not saying that's the best model, but some model that will really incentivize people to go into primary care, I think that would be a big winner in my mind.
Yeah. So before my last question here, I want to make sure I've addressed studio audience here. When we talk about the right care at the right time, is that a program that's being rolled out, or is it just more of an idea?
It's an idea. This is something at Michigan Medicine that we try to, that's one of our mantras: provide the right care, right place, right time. And I think that's, and certainly I didn't come up with that idea, but I think it's a great idea. And I think it is being looked at, more and more. We're in healthcare, any area of healthcare, we're trying to remember the center of all this is not the hospital. It's not the executives. It's not the health system. It's the patient.
Yep.
If everything we do focuses on how can we help those patients or people be healthier, then I think we're doing our job.
And my answer to the studio audience on that question is filling the care gaps between, the primary care providers are too busy taking care of sick patients. So who's taking care of the well patients, doing those screenings to make sure they stay well? And that's the project that is being rolled out right now. It's in about 15, 16 states. And it's linking doctors with the community pharmacy. So the community pharmacy becomes an extension to that doctor and then can provide those screenings in behalf of the doctor through a community care program that's under that doctor's direction. And so that's coming to the United States all over here shortly, and already in 16 different states.
What's that
You mentioned that
program
before,
called?
and I think that's a great thing to do.
Yeah. That's the Independent Pharmacy Provider Network is that program. So IPPN Hub. My last question for you, because I want to get back to the focus of the book here, Dr. Runge. What story or what would our readers really get from your book that's just going to stick with them?
Well, I hope that they'll take home the message that healthcare is very broad, but every part of it, from health promotion and health and prevention of disease and primary care to the most technically advanced therapies, they all have a place. And I think we need to shift our focus a little bit away from always thinking about the most advanced therapies. Those have to be there, but also how we can improve health. And you don't have to look around far to see that we've got lots of opportunities to improve health in the United States. And I hope that people who get the book and read it will feel free. I have a website. They can tell me they think I'm crazy in this area or that area, and that's fine. I'd love to hear back from people who read the book, and I hope it'll help them think about their own health and how they can help others. And I think there are lots of people. Tim, you mentioned earlier, I think you mentioned a professional basketball player. You know, sometimes these messages, they don't have to come from healthcare providers. They can come from other people that we work with who young people are more likely to listen to. Maybe they come from a TikTok star. I don't know.
Yeah, like our own Breck TikTok.
Yeah.
But I think and they'll come from Dr. Marshall, who I would add that and maybe it's your fiction writing that, although this is not fiction, it's visioning, but I think your fiction writing spilled over into the books. I just want people to know that it's not a dry read. It's not something you read to go to sleep. It's very exciting. It's very well written, and it's very, very intriguing and thought stimulating.
Well, thank you, Tim. I hope so, and thank you for this opportunity to speak to you all, and also get the word out about the great healthcare disruption, big tech, bold policy, and the future of American medicine.
Yeah, so we'll leave a link in the show notes for those that watch the replay on YouTube. But for those listening to Apple and Spotify podcast, where can they find that website, Dr. Runge?
The website is Dr. It's all one word, Dr. Marschall Runge, I think .com. I should know that. If you look me up, it's easy to find. But it's Dr. Marschall Runge, Dr. Marschall Runge.
Dr. Marschall Runge. Okay. And a great big thank you to you, Dr. Marshall. It's so great to have you on, talk about your book and promote it a little bit, because it is a wonderful read. And we appreciate your friendship to the show. And until next time, stay curious, stay empowered, and remember, wellness, it's in you.